Welcome to our video on secondary hyperparathyroidism associated with chronic kidney disease. After watching this video on secondary hyperparathyroidism associated with chronic kidney disease or CKD, you are expected to know the underlying pathogenesis of secondary hyperparathyroidism and its clinical implications. You are also expected to be able to recognize and treat secondary hyperparathyroidism. Secondary hyperparathyroidism is a major CKD complication that is related to abnormal metabolism of calcium, phosphate, and vitamin D. Untreated secondary hyperparathyroidism can lead to serious complications, including abnormal bone health or renal osteodystrophy with increased risk of fracture. Osteitis fibrosa cystica is a high turnover bone disease characterized radiographically by subperiosteal bone resorption of phalanges and distal radius, thinning of distal clavicle, bone cyst formation, and generalized osteopenia. Calcific uremic arteriolopathy is a condition characterized by systemic medial calcification of arterioles and painful ischemic necrosis of skin and subcutaneous tissues. This condition is associated with mortality up to 45 to 80% within 1 year. Vascular calcifications and accelerated atherosclerosis, refractory anemia, thought to be due to bone marrow fibrosis with ineffective erythropoiesis. With all of these complications, secondary hyperparathyroidism is associated with increased mortality. Before we talk about the pathogenesis of secondary hyperparathyroidism, we need to briefly discuss about vitamin D metabolism and the functions of two hormones, namely parathyroid hormone or PTH and fibroblast growth factor 23 or FGF23. Starting with vitamin D metabolism. In vitamin D metabolism, we start out with 7-dehydrocholesterol, which gets converted to cholecalciferol by UV light. Cholecalciferol is then hydroxylated at the 25th carbon by the enzyme 25-hydroxylase in the liver to become 25-hydroxyvitamin D. This is subsequently hydroxylated at the first carbon by the enzyme 1-alpha-hydroxylase in the kidneys or macrophages to become 125D, which is the active form of vitamin D. 125 vitamin D serves to stimulate gastrointestinal or GI absorption of both calcium and phosphate. 125D may be inactivated when it gets hydroxylated at the 24th carbon by 24-hydroxylase. A few words about parathyroid hormone or PTH. Parathyroid glands produce PTH. PTH stimulates bone resorption, which increases both calcium and phosphate levels. PTH acts on the kidneys to increase renal calcium reabsorption to increase blood calcium level. PTH also activates the enzyme 1-alpha-hydroxylase in the kidneys to convert 25-vitamin D to its active form 125D, which then increases GI absorption of calcium to increase calcium level. 125D also increases GI absorption of phosphate. While PTH predominantly serves to increase calcium level, it also increases phosphate excretion by the kidneys. Parathyroid glands have both calcium sensing receptors and vitamin D receptors. Calcium sensing and vitamin D receptors detect minor changes in extracellular calcium and vitamin D levels, respectively, and adjust PTH levels accordingly. The binding of calcium and vitamin D to their respective receptors provide a negative feedback to parathyroid glands to reduce PTH secretion. A few words about fibroblast growth factor 23 or FGF23 as it relates to phosphate and vitamin D metabolism. FGF23 is a bone-derived hormone that acts on the kidneys to induce phosphate excretion. FGF23 also reduces blood level of the active 125 vitamin D by inhibiting 1-alpha hydroxylase, the enzyme that converts vitamin D25 to 125, while stimulating 24-hydroxylase, the enzyme that inactivates 125D to 124-25D. The reduced 125D level leads to reduced GI absorption of calcium, thereby lowering blood calcium levels. FGF23 also inhibits the proliferation and function of parathyroid glands, which also contributes to reduced blood calcium levels. Summarizing the functions of PTH and FGF23. The primary function of PTH is to increase ionized calcium level in response to reduced blood calcium levels. PTH achieves this by increasing bone resorption, renal calcium reabsorption, and active 125 vitamin D levels, the latter to increase GI absorption of calcium, all serve to increase serum calcium level. PTH also induces phosphaturia. FGF23 is a bone-derived hormone. Its major function is to induce phosphaturia. Unlike PTH, FGF23 acts to reduce 125D level. It does this by inhibiting 1-alpha hydroxylase, the enzyme that turns 25D to its active form 125D, while stimulating 24-hydroxylase, the enzyme that inactivates 125D. Additionally, FGF23 also has an inhibitory effect on PTH. Essentially, FGF23 induces phosphaturia and counteracts the calcemic effect of PTH. The common function for both PTH and FGF23 is phosphaturia. The difference is PTH functions to increase serum calcium when its blood level is low, while FGF23 antagonizes everything that PTH does for calcium. Now that we understand vitamin D metabolism and what PTH and FGF23 do, we can discuss the pathogenesis of secondary hyperparathyroidism. We start out with our normal parathyroid gland with its calcium-sensing receptor and vitamin D receptor, both acting to keep the parathyroid gland in check based on small changes in blood calcium and 125D levels. When there is reduced kidney mass and function, one of the first things that happens is increased phosphate retention. Phosphate retention per se can stimulate the parathyroid gland and contribute to secondary hyperparathyroidism. More importantly, the increase in phosphate levels stimulates the production of FGF23. FGF23 inhibits 1-alpha while stimulating 24-hydroxylase, both leading to reduced 125 vitamin D level. Reduced 125 level leads to reduced GI calcium absorption, which then leads to reduced blood calcium. The lower 125 and calcium levels lead to the loss of negative feedback to the parathyroid gland, thereby allowing the parathyroid gland to continue to proliferate and secrete PTH, giving rise to secondary hyperparathyroidism. The accumulation of phosphate in CKD can also precipitate systemically with calcium to further lower serum calcium and further contribute to secondary hyperparathyroidism. Reduced kidney mass and function can also reduce 1-alpha hydroxylase activity because this enzyme is in the kidney. This leads to reduced 125 level, which contributes to secondary hyperparathyroidism. Poor diet and reduced skin and liver metabolism of vitamin D precursors can also lead to reduced 125D. Finally, In the uremic milieu, parathyroid glands have been shown to have reduced expressions of both calcium sensing and vitamin D receptors and reduced ligand binding affinity to recognize negative feedback from calcium and vitamin D respectively, thereby allowing for uninhibited proliferation of parathyroid glands. Secondary hyperparathyroidism may be diagnosed in patients with CKD and is characterized by elevated serum PTH levels with associated normal to high serum phosphate and normal to low serum calcium. The pathogenesis of secondary hyperparathyroidism is complex, but we can tease out 4 major stimuli and accordingly treat the condition. Number 1, there is phosphate retention with or without overt hyperphosphatemia. Number 2, there may be reduced vitamin D precursors. Number 3, there may be reduced 125 vitamin D levels. And number 4, there may be reduced expression of calcium sensing receptors and or reduced affinity of calcium sensing receptor to calcium in parathyroid cells. Starting with problem number 1, phosphate retention and hyperphosphatemia. The management of phosphate retention leading to hyperphosphatemia includes dietary restriction and the use of phosphate binders. What are involved in dietary phosphate restriction? Organic phosphorus from plant and animal sources are preferred over inorganic sources found in preserved foods with phosphorus containing preservatives or flavor enhancers because of greater GI absorption with inorganic phosphorus compared to phosphorus from plant and animal sources. Of all organic sources of phosphorus, phosphorus derived from plants is preferred because it does not get absorbed as well as that from animal sources. In general, fresh and homemade foods without inorganic phosphate-containing additives are preferred. Finally, before we restrict any kind of dietary intake, we have to make sure that patients are well educated on the topic with or without the help of a dietitian to avoid malnutrition. We can also reduce serum phosphate levels with the use of phosphate binders. These agents bind phosphates that come from dietary intake. Phosphate binders are therefore given with meals. There are 2 types of phosphate binders, calcium-based and non-calcium-based. Calcium-based phosphate binders are phosphate binders that contain calcium. They are preferred in patients with concurrent very low serum calcium levels, but should be avoided in patients with high serum calcium levels, known vascular calcifications, or very high phosphate levels due to concerns for systemic calcium phosphate precipitation. Examples of calcium-based phosphate binders include calcium carbonate and calcium acetate. Non-calcium-based phosphate binders contain cations other than calcium. These agents are preferred in patients with normal to high serum calcium levels or patients with known vascular calcifications. Examples of non-calcium-based phosphate binders include sevelamer, lanthanum, and other iron-containing compounds. Another stimulus for secondary hyperparathyroidism is the deficiency of 125 vitamin D. However, before blaming our problem on 125D deficiency, we have to make sure we have adequate vitamin D precursors. The second problem that we need to focus on is therefore the lack of 25D, the precursor of 125 vitamin D. 25 vitamin D is routinely checked in patients with CKD with stage 3 or greater every 3 to 12 months depending on CKD stage and initial level. Patients with levels below normal range may be supplemented with 2 commonly used formulations, including ergocalciferol and cholecalciferol. Common dosages are given here for your reference. If PTH level remains high despite the correction of hyperphosphatemia and adequate supplementation of vitamin D precursors, we can assume that there is insufficient conversion of 25D to 125D, the active form that is necessary to suppress parathyroid glands. Supplementing active vitamin D is the third step in the management of secondary hyperparathyroidism. For your reference, this table lists vitamin D formulations that are already hydroxylated at carbon 1, the carbon that is normally hydroxylated by 1-alpha hydroxylase. These agents are also referred to as vitamin D receptor agonists. Note that prior to the use of vitamin D receptor agonists, hyperphosphatemia should be controlled first because active vitamin D can also increase GI absorption of phosphate and can worsen the existing hyperphosphatemia. The fourth problem leading to secondary hyperparathyroidism is the reduced expression of calcium-sensing receptors, as well as reduced binding affinity of these receptors to calcium. Without the appropriate activation of calcium-sensing receptors, proliferation of parathyroid glands is uninhibited, thereby contributing to secondary hyperparathyroidism. Calcimimetics are agents used to activate calcium-sensing receptors to inhibit parathyroid gland growth and PTH release. There are two agents used for this purpose. Cinacalcet is a positive allosteric modulator of calcium-sensing receptors. Basically, cinacalcet binds to calcium-sensing receptors and changes the conformation of the receptors to make them more sensitive to extracellular calcium. Etalcalcetide is a direct calcium-sensing receptor agonist, which means it can directly activate calcium-sensing receptors without having calcium around. The activation of calcium-sensing receptors by either cinacalcet or etalcalcetide signals parathyroid glands to stop producing more PTH. Currently, the use of calcimimetics is only recommended in dialysis patients, not in pre-dialysis CKD patients, due to the lack of safety data in the latter group. Note that because calcimimetics reduce PTH levels, hypocalcemia is the major side effect and must be closely monitored. In summary, secondary hyperparathyroidism of CKD arises from multiple problems, including increased phosphate retention to cause hyperphosphatemia, reduced vitamin D, and reduced parathyroid sensitivity to extracellular calcium and active vitamin D. In order to treat secondary hyperparathyroidism, we need to target the following. Number 1, reduce phosphate burden with dietary restriction and the use of phosphate binders. Number 2, supplement patients with vitamin D precursors. Number 3, supplement active vitamin D receptor agonists after phosphate levels have been relatively normalized. Number 4, in dialysis patients only, calcimimetics may be added if secondary hyperparathyroidism has not been controlled despite corrections of all above problems. Patients on calcimimetics must be monitored for hypocalcemia. Are you ready for a challenge? What would you do for each of the following patients? Pause the video and try to come up with a plan for all of these patients. Resume the video for the correct answers. Here are the answers. At this time, you should know the underlying pathogenesis of secondary hyperparathyroidism and its clinical implications. You should also be able to recognize and treat secondary hyperparathyroidism. The end.